case of breast cancers. You recommend to follow by MRI or again to repeat mammogram again to assess this is the state after down staging by chemotherapy.
Well, for patients with neoadjuvant chemotherapy, our practice is to put a clip in the lesion, and then we will just complete the cycle of chemotherapy, and then the patient will go for biopsy. So we don't always reassess the patient with MRI.
Not recommend to assess by MRI.
Regarding the follow-up of the chemotherapy, because as a surgeon or an oncologist, they want to see the response of the chemotherapy. So usually we follow with ultrasound. If the lesion is seen by ultrasound, it's the easiest than mammogram, and it will give the volume. Usually when we diagnose a case of cancer on mammogram, we do an ultrasound to get the volume of the mass, and then after the chemotherapy, finish the first cycle, we again measure the volume by ultrasound. But sometimes they vanish completely, so you cannot see them. So this is again good response.
Excuse me, I will add 2 comments regarding radial skull. It's as doctor has mentioned, radial skull is a benign hyperplastic change of the breast, and the idea it has really the shape of a star. And between these benign changes, you can find low-grade tumor or ADH or LCIS, DCIS, or even tumors. And that's the idea. If you do core biopsy, you are targeting the center of the radial skull. So even if it's benign, but the surgeon insists to do biopsy before, because if it's cancer, it's another way of surgery. So even if it's benign, it's recommended to excise it. You can, if it's large, you can bracket it or put 2 wires. To remove the whole thing and send it for the pathology, you will be sure that you know all the area. If you do core, you are targeting maybe the center of the benign finding, and you can miss LCIS and DCIS. The second comment regarding follow-up after neoadjuvant chemotherapy, we are doing the same follow-up with the ultrasound. But if the patient is going for a breast-conserving surgery, lumpectomy, you have to do mammogram before the surgery to look for calcification. Sometimes there's paradoxical effect that you see suddenly the calcifications are filling the breast. And this will not be a candidate for breast-conserving surgery anymore. Okay. Yes.
There is another question about fine needle aspiration limitations. In other words, some of the cases, non-palpable breast mass and less than centimeter diameter or dimensions. So at that time, some of the cases refused by radiologists to do ultrasound-guided FNA. So my question is, there is any limitation for fine needle aspiration for non-palpable breast masses, especially for the small sizes?
Usually, we don't do much fine needle aspiration in my practice. If we do it, it's usually for lymph nodes just to see whether there's a metastasis there. I'm not sure what the practice is in your
we are not using also FNA anymore.
It's obsolete. FNA is obsolete now. Usually we do core biopsy. And it's a standard that if the lesion is less than 1 centimeter, it's difficult to take a core biopsy, but it's easier to take vacuum-assisted biopsy. If the lesion is seen by ultrasound, we do vacuum-assisted biopsy under ultrasound guidance. But please, no more FNAs.
Why?
Because of the low sensitivity of the...
No, it is high sensitivity,
No,
but you need expertise. No, sorry, don't say obsolete. There is a lot of people that are doing FNAs.
But if this facility for biopsy is not available, what we can do?
What you can do.
What is the
I guess
What's
if
the question?
The procedure, as she said, by using vacuum.
You can do core biopsy. We do actually even 4 and 8 millimeter, but depends on the expertise. If not, you have to do surgical excision then. If you see such suspicious mass on the mammogram, it looks speculated mass, you cannot reach it with vacuum, and then you have to go for wire localization.
No, I'm telling you, in the case we cannot use mammography for young patient, for young patient for 20s, and there is family history of cancer. You got my point? So the mammogram cannot be done in this case. Dense breast and something.
Young patient and you see suspicious mass?
Not suspicious mass. There is a non-palpable mass, non-palpable in a young patient, and this mass is around 5 millimeters or 6 millimeters.
How you detect this lump?
This side.
Palpable mass. How you
No, not palpable, but it is ultrasonography detected.
You can do ultrasound guided biopsy. That's the only choice.
That's what this is.
Yeah, you can do ultrasound guided biopsy or vacuum assisted if you have.
And I'll listen just to say something. What is your
The question is, there is any limitation for the size for this biopsy or not? This is my question. What I mean, some of the cases refused by a radiologist. He said it looks to be benign. No need for fine needle aspiration. This is my question.
No, sorry.
So I'm asking for radiologist.
You know, you have the
opinion.
criteria to decide which lesion to biopsy. You cannot biopsy every finding on ultrasound. So it depends on the radiologist's suspicion. If he thinks it's suspicious, I'm sure he will give it like a BIATS 4. And if it's 5 BIATS, you know, 4, it's A, B, and C. If it's C, it means you are thinking more malignant. If it's A, you are thinking benign. And now with the new BIATS recommendation, the ACR 5th edition, BIATS 4A lesion, like BIATS 3, you can follow up them. It depends on the clinician and the patient agreement. So not even all BIATS 4A lesion you have to biopsy. So if he thinks it's malignant, suspicious, or BIATS B or C,
it's okay.
they have to biopsy, even if it's small. And
right.
even if you think something is suspicious and you cannot find it by ultrasound, you have to go for surgery. You got it all the way before.
I hope we answered your question because you are asking about the size limitation.
Yeah.
No size limitation.
No size.
Any small size we can biopsy by any modality.
This is my question.
Okay, it is the time now for break, and lunch and prayer, and we will start at 2 o'clock.
Thank you.
Thank you to all.
Good afternoon. We will start now to have the last session in our conference. It will be directed by Dr. Anuha Barido, a breast surgeon from King Fahd Specialist Hospital.
Bismillah ar-Rahman ar-Rahim. If everyone can be seated, please, and we'll start the next session. We'll start with Dr. Iman Baroum. She's a consultant radiologist and breast imager and head of the radiology department at King Abdullah Medical Complex in Jeddah. She's also the head of the coordination committee of the Jeddah Breast Cancer Screening Pilot Program. Dr. Iman will be speaking about the role of MRI in breast cancer diagnostics and the breast cancer screening program. Thank you.
Assalamu alaikum. I'll have a brief talk about the role of breast MRI in breast cancer screening. Breast MRI can be used in addition to mammography to detect breast cancer in its earliest stage for some women who are at high risk for developing the disease. There is no doubt that the high-risk women for breast cancer, they need to be screened more aggressively than the general population. Who are the high-risk groups? The high-risk groups, those women who have known BRCA1 or BRCA2 gene mutation, or BRCA carrier, or have a 20% or greater lifetime risk of breast cancer. This lifetime risk can be determined by using some scientific tool that use statistical analysis and calculations. Some of these methods are based on family history, and some of them are based on predisposing factors of cancer. If they have first-degree relative, parent, brother, sister, or child with BRCA1 or BRCA2 gene mutation, but themselves have not had genetic testing, or received radiation therapy to the chest between the ages of 10 and 30 years, like those patients with lymphoma, or they have conditions that increases the risk of breast cancer, such as Lee-Fermani syndrome or Cowden syndrome or other syndrome, or have first-degree relative with one of these syndromes. So for these high-risk groups, the international recommendations, the American Cancer Society recommends that all high-risk women have breast MRI and mammogram every year for most women. These combined screening should start at the age of 30 years and continue as long as the woman is in good health. Also, the National Comprehensive Cancer Network now recommends considering breast MRI yearly, on yearly basis, accompanied with a mammogram. The current screening strategy for women at high risk, if they are BRCA1 mutation, so start at the age of 30 or 5 years before the youngest affected family member. From age 30 to 40, MRI every 6 to 12 months, with an ultrasound every 6 months. From age 40 to 50, MRI every 6 to 12 months and ultrasound every 6 months, and digital mammography every 12 months. From age 60 onwards, MRI every 12 months, as well as digital mammography. For those with BRCA2 mutation, they start screening at the same age, 30 years or 5 years before the youngest affected family member. And from age 30 to 40, MRI should be done every 12 months. Because in BRCA1 mutation, it's recommended to be every 6 months. Because cancers in patients with BRCA1 mutation, it's more aggressive than in BRCA2. And ultrasound every 12 months. If breast not dense, so they do annual digital mammography. They do only one view, the MLO. From age 40 to 70, MRI every 12 months and digital regular screening mammography every 12 months. For those women who have no documented mutation, they start at the same age, and their screening is almost like the regular people, MRI every 12 months, between 30 and 40, and from age 40 to 70, every 12 months, as well as mammogram. The second group, those who have moderately increased risk, i.e. they have a lifetime risk between 15 and 20%, or women who have had breast cancer, previous history of breast cancer, DCIS, lobular carcinoma in situ, or precancerous conditions like ADH, and also women with dense breasts based on mammography. All those are categorized as moderately increased risk. And the recommendations for such group is that there is not enough evidence to make a recommendation for or against yearly MRI. And the American Cancer Society suggests that or recommends that the woman should discuss her case with her physician for adding breast MRI for screening to their yearly mammogram. The third group is the low risk group, which are women whose lifetime risk of breast cancer is less than 15%. And the American Cancer Society recommends against MRI screening for this group. They should have the regular screening protocol. It is recommended that women who get a screening MRI, they should do this in a facility that provides MR-guided biopsy. Because if she did the MRI somewhere else and then she needed the biopsy, she should repeat the MRI in the facility that will provide the biopsy. So the examination will be done twice. So it's very crucial that you do the screening MRI where you can do the biopsy. There are some usually known limitations of breast MRI. Some of them are, you can consider them a myth, like increased false positive rate and increase in anxiety for women, for many women. Nowadays, with the current technology of MRI, with the advancement in the scanners themselves, with the advancement in the protocols, and in the sequences, and in the coils themselves, and the presence of when you evaluate a case, you evaluate the dynamics, i.e. how the lesion respond to contrast enhancement, and also you evaluate the morphology, and with the presence of expert radiologists, I think the false positive rate has reduced very much. MRI cannot visualize microcalcifications, yes, and most of DCIS, they present like with microcalcifications, and these microcalcifications are seen on mammography only. MRI is more expensive compared to mammography, yes, if we are stick to the conventional protocol, and it's time consuming also. There is something called the must-have modality. What is the must-have modality? A prospective multi-center cohort study conducted by Dr. Kuhl and colleagues, which is the EVA trial. I think most of the people are aware of that. They screened 687 women at high risk of breast cancer. The lifetime risk is 20% or more for up to 3 years. They did for them annual clinical breast exam, mammography, ultrasound, and MRI. And all these tests has been read independently and in different combinations. And the result of this study was that a total of 27 breast cancers were diagnosed. 11 of them were ductal carcinoma in situ, which represent 41%, and 16 invasive cancers representing 59%. And there were no interval cancers during the 3 years. This graph represents the sensitivity of every modality and the combination. So we're talking about high-risk group. So mammography alone is sensitivity in detecting malignancy was 33%. Mammogram and ultrasound was 48%. MRI alone was 93%. So imagine the gap between both. MRI and ultrasound 93%, meaning ultrasound did not add much to MRI. MRI and mammogram is a good combination. The sensitivity went to 100%, and the 3 modalities together is 100%. So this indicates that mammography, MRI is highly sensitive in screening patients at high risk of breast cancer. And this is another study that confirms what Kuhl have said. It's a study by Sardinali. And MRI was more sensitive, and these are the results. MRI was more sensitive than the rest of the modalities. The sensitivity was 91%. Clinical breast exam, 18% its sensitivity in detecting cancer. Mammography was 50%, ultrasound 52%, and combined ultrasound and mammography was 63%. So we can come up to a conclusion that MRI is largely outperform mammography and ultrasound and their combination for screening women, high-risk women below and over 50 years of age. So mammography alone is not suitable for screening women at increased familial risk. Only MRI offers adequate sensitivity and should constitute the basis of any screening protocol for high-risk women. It is the must-have imaging modality. Some facts about mammography is that it detects breast cancer on the basis of either microcalcifications or architectural distortion or speculations. And these changes, they reflect regressive changes such as hypoxia, necrosis, and fibrosis. So as a result, mammography has a detection bias towards slow-growing cancers. In contrast, or unlike MRI, it detects breast cancer that determined by the angiogenic and protease activity, and which had direct correlation with carcinogenesis and cell proliferation and metastatic growth. So, meaning that MRI detection of cancer and DCIS is based on toward biologically active and prognostically relevant disease. Usually tumors detected by MRI, they are of moderate grade or high grade, unlike mammography. So by using an imaging test that has a bias toward rapidly growing, biologically aggressive, invasive disease may help avoid overdiagnosis. This is the issue and the controversy. But current breast MRI protocols are designed for diagnostic rather than screening purposes, and therefore they are time-consuming in doing the examination and in reporting the examination. Which contributes to the modality's relatively higher cost and limited availability. So what about having a simplified protocol that improves breast MRI screening? This study is a proof of concept by Dr. Kuhl and colleagues, and the protocol was tested in 443 women at high risk for breast cancer and who have negative mammography. The protocol consists only of the first post-contrast subtracted image and their MIP reconstructions. And radiologists reviewed the MIP images first, and then if there is abnormality, they go and analyze the fast images for further categorization. Later, all the patient images were analyzed using the full diagnostic breast MRI protocol. So all the patients, they have this short protocol and the full protocol, and both results are compared together. So patients with this short protocol, they have an average table time of 3 minutes compared with 21 minutes for the full MRI protocol. In addition, the experienced radiologists were able to read the MIP images in about 2.8 seconds and the fast images in 28 seconds. So the whole MRI report is done in like 3 seconds, 30 seconds. 11 breast cancers were diagnosed. All were classified as intermediate grade or high grade. 4 of the cancers were DCIS and 7 were invasive. And the mean size of the cancers was 8 millimeters. The streamlined or the FAST protocol detected 9 of 11 cancers. So the sensitivity of the FAST protocol was 82%, which is high. And the specificity of the FAST images at 94.4 is equivalent to the full MRI protocol. There was 33 false positive occurred using FAST images compared with 35 for the full protocol. The negative predictive value of the streamlined protocol, which is the FAST protocol, was 99.6% compared with the 99.8% for the full protocol. So if you are taking the time factor, FAST screening thereby compares favorably with mammographic screening with regards to the time needed to acquire and report the images, which is 3 minutes. This is an example for a patient 56 high risk group. She had a mammogram reported as normal, and then she had a screening MRI. This is MIP images. It showed strongly enhancing very clear lesions in the left retroareolar area. So as a radiologist, it won't take from you 2 seconds to pick up the abnormality. Yes, somebody will tell you, give me a piece of cake. Now, the breast, there is no background enhancement, only the lesion enhancing. But even the trained radiologist, with the presence of the background enhancement, they can pick up the abnormal enhancement areas with certain criteria. These are some links to breast cancer risk assessment models to calculate the lifetime risk of a woman. You have the BRCA-PRO, close method, and Gale method, and others for those people who want to measure, assess yourself, the lifetime risk for yourself. Just go to these websites, and you found drop menus. You just answer them, so you calculate your own risk and your family risk. Thank you very much.
She's assistant professor at Department of Surgical Oncology, University of Texas, Anderson Cancer Center, Houston, in Texas. And she is clinical instructor, general surgery and trauma, University Carolina, as a clinical instructor. And general surgery, trauma staff, walk mid faculty of physician, walk medical center, North Carolina. Okay. And she will the power, and the subject is power of percutaneous breast biopsy in breast cancer diagnosis.
Yes. Okay, so one of the first lessons they teach you in public speaking is to know your audience. When I looked at the program, I saw it was the second to last talk after a 2-day conference, after lunch. So this is going to be short. It's not going to be quite as dense as yesterday's. So I want to talk about percutaneous breast biopsy, and I have to admit I have an ulterior motive here, in that a lot of my patients actually come from Saudi Arabia, Qatar, Jordan, and they come to MD Anderson maybe in the middle of therapy or at the beginning of therapy. And so this is going to be sort of my plea for biopsies and clip placement, because sometimes they're in the middle of therapy and we have very sketchy records of what happened before, and now we're just doing imaging after some chemotherapy response. But mainly this is my love letter to radiologists. So the radiologists in the room, this is your love letter today. Percutaneous biopsy, this is why I love radiologists. Because behind every surgeon is a fantastic breast radiologist. They are what makes me look like a rock star to my patients. Most of our patients, I'm a second opinion. They go to another surgeon based on the local imaging. They come to MD Anderson. They have to get repeat imaging. We have fantastic breast radiologists. I mean, I cannot begin to praise them enough, who always find things that they didn't see on the local imaging. And then I get to be the face of those new findings. So I sometimes get credit for what the radiologists have actually done. But without a doubt, as surgeons, we really appreciate radiology. because we're lost without your roadmap. You basically lay everything out for us and tell us exactly how to operate. Comprehensive staging and biopsy is crucial to operative management, and I won't say not only operative management, but multidisciplinary management, because it helps us decide how we're going to treat the patient. The radiologists are the difference between a successful one-stage operation versus multiple operations, maybe missed opportunities for neoadjuvant chemotherapy and downsizing. So it's very crucial. We've talked a lot about screening, and this is probably too late in the session. I should have brought this up yesterday. So I want to go through a few case studies, and these are patients I've had within the last 6 months. So they're real-life examples, not things that I've been scrounging around for 20 years to find. This is a common. So this is a case of incomplete biopsies. This was a 55-year-old woman initially treated at another hospital. Her ultrasound showed 3 small lesions when she initially presented. 1 o'clock was biopsied, was invasive ductal carcinoma. 2 o'clock, biopsied, invasive ductal carcinoma. 6 o'clock, no biopsy performed, but they called it multicentric disease. She got an MRI, which showed a 4.6 centimeter mass with 2 satellites. One was immediately anterior, one was anterior inferior, and she had suspicious lymph nodes. On MRI, these satellites were never biopsied. She started chemotherapy because she was HER2 positive, ERPR negative HER2 positive, so she started TCH by the local medical oncologist. So she came to MD Anderson after completing neoadjuvant chemotherapy and said, I want surgery here. I said, great. So we did a mammogram, and we see a small area of calcifications at 2 o'clock. However, the calcifications are medial to the clip, so I have no idea if that clip is where the initial mass was. Has it migrated? Is this an area of residual disease? Only one clip was seen, because even though they had biopsied one of the satellites, they did not place a clip. The ultrasound shows a clip with no residual mass, and at least 4 suspicious axillary lymph nodes with the index measuring 2.6 centimeters. So here's my situation. I have an outside report that says they've got an index mass, 2 satellites on ultrasound. One I know was cancer, but I don't know where it is. One I have no idea if it's cancer or not, plus 2 satellites on MRI that I have no idea if those are the same things seen on ultrasound. And now she has very minimal residual disease on imaging. So unfortunately, I told her she needed a mastectomy because I had no way to find those other areas or to determine if she was an appropriate BCT candidate. On the mastectomy specimen, she had a 3, and this was a large woman, large breast. I could have easily gotten this out with a lumpectomy and no one would have ever known the difference. 3 centimeters of disease with only 2% cellularity, so very minimal residual disease. 2 out of 24 lymph nodes. It was a true missed opportunity for BCT, and this was an obese woman. Because we really didn't know much, but we knew she had nodal disease. We knew she was going to get post-mastectomy radiation. Our plastic surgeons wanted to delay all reconstruction, so she has a true absence of the breast for at least a year. She had recurrent seroma. She got hospitalized with an infection. These are all things that could have been prevented if she had gotten the adequate staging up front. But luckily, I'm going to show you some success stories because it's not all bad news. Here's a 52-year-old woman. Screening mammogram showed a 12 millimeter mass at 12 o'clock. She got a biopsy, invasive tubular carcinoma, so low-risk lesion. They put a clip in. That's all great. She comes to MD Anderson. She was coming from Florida. And she gets her mammogram. They see the mass with the clip well-centered, and you can see it right there, 12 by 9 by 10 millimeters. We're all the same so far. On ultrasound, they see that biopsy-proven mass at 12 o'clock, 6 centimeters from the nipple. It's 8 millimeters. But they see a second mass at 12 o'clock, and you can see it here, measuring 5 millimeters. They performed an FNA, and a clip was placed. I know there was some discussion about core versus FNA earlier today. We always core the primary lesion, and then often they'll just do an FNA of a secondary lesion that they think is a satellite, because we're really just confirming that this is cancer or not cancer. We don't need receptors and things like that. So the FNA showed fragments of ductal epithelium and a lot of pathologic stuff, as you know. Areas of hyperplasia with duct structures raised concern for atypical duct hyperplasia or carcinoma in situ versus lobular carcinoma in situ. In the end, they recommended excision. So, small-breasted woman, I told her she needed to have a mastectomy. We did a skin-sparing mastectomy, and as part of our practice, we always do an intraoperative x-ray to make sure that we got all of the areas in question. And you can see the 2 clips in the mastectomy specimen. We got both areas. It looks like our margins are negative. Surgical pathology showed that invasive tubular carcinoma. This was the whole reason she came to me to begin with. But that other mass that they saw on ultrasound showed invasive lobular carcinoma, measuring 2 centimeters. So actually more concerning than her primary tumor, probably. And I just want to stress, this is seen on ultrasound. We don't routinely get MRIs at MD Anderson. Ultrasound is very good, and they picked it up. She also had multifocal lobular carcinoma in situ and negative sentinel nodes. So this is definitely one that good imaging helped us. One more. A 58-year-old female had a history of left arm shingles right before I saw her. She got a mammogram that showed calcifications at 12 o'clock, pretty small lesion. She got an ultrasound that shows a 1 centimeter mass. They saw multiple enlarged axillary and neck lymph nodes. They got an MRI. It showed a 5 by 3 centimeter mass. So they did a core biopsy of this breast mass that showed low-grade invasive ductal carcinoma, no markers performed. They did not biopsy the axillary lymph nodes. Unfortunately, as happens to be in practice a lot of places in the U.S., as much as we try to break them of this habit, they still do it. She had breast cancer, so she got a PET scan. And in it, they saw that axillary lymphadenopathy, but they told her, you know, the SUVs are pretty low. This doesn't look like cancer. This is probably related to your shingles. So you have a small breast cancer. Maybe it's bigger based on the MRI, but it's low grade. Don't worry about those lymph nodes. Luckily, she was a patient, she was a friend of one of my patients who said, you need to go to MD Anderson, and she did. We got the mammogram, calcifications measuring 11 millimeters, so that was pretty consistent. They see the ultrasound, see the mass measuring 1.3 centimeters on ultrasound, but then when they looked at the lymph nodes, once again, they saw extensive adenopathy, but this time they stuck a needle in it. They put a needle in the axillary lymph node and the supraclavicular node. Both contained breast cancer metastasis. Okay. We repeated her core biopsy because we didn't have good markers on it, and she was, what do you know, triple negative, invasive ductal carcinoma, ER negative, PR negative, HER2 negative. So this plan changed from a planned lumpectomy with sentinel node, in which case they would have found some positive nodes, probably wouldn't have cleared them all. They would have had to give her chemotherapy, and it would have been a big shock, right? But now we had great imaging. We had a lot of information. We now know this woman has a triple negative N3 disease, so we started with neoadjuvant chemotherapy. Still planning to do a lumpectomy. I'm hoping she'll get some downsizing. And then an axillary lymph node dissection. So doing these biopsies, instead of just supposing, oh, you know, those lymph nodes look suspicious or they don't look suspicious. It's so easy to stick a needle in, get a pathologic assessment, and then we know for sure what the patient actually has. It allows us to assess the treatment response. Hopefully we'll get a smaller breast resection out of this, and it helps us to better plan her surgery. So this is just my plea for percutaneous biopsy. Only about 20 to 30% of women who have a biopsy actually have cancer. So unfortunately in the U.S. there's a real temptation. A general surgeon sees a patient with a breast mass. He doesn't want to wait for a biopsy, or he doesn't want to lose the patient. So they take them to the operating room and they excise the mass. And we really, lose so many opportunities when we do that. So I would just make a plea for percutaneous biopsy. There's less pain, there's less bleeding, lower risk of infection, it's cheaper, there's no anesthetic risk, and if a woman has to undergo multiple biopsies in her life, you retain the breast for the time that she really does have cancer. Because unfortunately, sometimes women come in, they've had 3 benign lumpectomies, benign excisional biopsies in a breast. Now they have a small cancer, but they just don't have much breast tissue left. The other thing that's very important to surgeons, and I think medical oncologists, is a good nodal evaluation. Knowing the pathologic nodal status is one of the most useful aspects of our planning. It helps us to determine the need for chemotherapy. As a surgeon, it helps me know if they're going to need post-mastectomy radiation, which really changes our reconstruction plan. We know that a false negative rate of physical exam is 45%. So really can't believe our fingers on what we think is cancer and what we don't think is cancer. Ultrasound's a lot better. Nodal ultrasound with FNA of abnormal nodes, and I'll let the radiologists in the room debate whether you want to do core or FNA of these nodes. At MD Anderson, we do FNA. Sensitivity is 86%, obviously very good specificity. If you see cancer cells, there's probably cancer there. Requires a skilled operator, proper slide preparation, expert cytology, and that's not available everywhere. So in those circumstances, core biopsy probably is better. But the advantages of doing a biopsy, it spares women unnecessary sentinel node procedures, and it's a more cost-effective approach. So just in summary, what the surgeons need from the radiologists in the room: biopsy of all suspicious lesions, even if it's close to the index, because if the index shrinks, we still need to get that satellite lesion. Place clips. More clips, the better. Biopsy to determine the extent of disease if it's a heterogeneous large area. Biopsy and clip all satellite lesions. I hope you've gotten that. I've said it a million times now. Nodal regions, assess all nodal regions, not just the axilla, but the infraclavicular, supraclavicular regions as well. We also look at internal mammary lymph nodes. Biopsy abnormal lymph nodes. Consider clip placement, and that's a whole other discussion. That's a new change in the way we approach these in America, is we're now putting clips in the lymph nodes, and we can discuss that at another symposium. Biopsy infraclavicular or supraclavicular nodes so that we can accurately stage, and then assess the internal mammary nodal region if appropriate. So in summary, imaging with biopsy and clip placement creates a map for the surgeon. Biopsy results often alter our management therapy and are crucial to how we approach these patients. And knowing as much as possible allows us to optimize therapy. We can pick the best treatments in the best order. We can enroll patients on clinical trials to give us all the information that we need for future generations of women. We get to perform one surgery, and it's the right surgery. And it can sometimes limit our extent of resection. Once again, I just want to thank you for the invitation to be here. This has been just a great pleasure to get to meet everybody and be involved in the discussions.
Thank you, Dr. Asudran.
So, thank you. Yes, if we can invite Dr. Christopher Maria DeWolf, who's currently the medical director of the breast cancer screening program in the canton of Bern, and he will be speaking about requirements of a breast screening program.
So good afternoon, for those who are left, or who are still here. I modified a little bit my presentation because of everything what I heard. I thought maybe I'll add some more slides and delete some other ones. My talk was supposed to be about requirements for a breast screening program. I hope I remember all my slides now where I put them, but I'll go through them and I'll explain what I see. After today, I just put up again the second picture of the European, oh, that will work also. The second edition of the European guidelines. I've been in charge with the European guidelines to select always the covers of the guidelines. And I must say today I feel a little bit like this radiologist that doesn't know what to do with all those women around him. Because I'm a little bit puzzled sometimes if I hear what is going on in different regions and in neighboring countries here. The experience in Europe shows that successful implementation of population breast cancer screening programs requires, and I've said it more times, long-term political commitment, sustainable resources, because also long-term political commitment. If you start a screening program, you need at least 10 years of follow-up, because that's the minimum before, otherwise you don't see any results. If you make a shorter follow-up, if you screen a woman and you detect a cancer, and that cancer may not kill her anymore, you need a time to know that she's not been, that she's been saved thanks to the screening. You need sustainable resources, because without money you cannot do it. You need trained professionals, radiologists, radiographers, but also staff members. And you need a comprehensive quality management program, what takes into account physical technical quality, automated invitations and appointment system, distribution and transport from mammographies to make your results management, follow-up of monitoring and evaluation, and also define standard operation procedures. In fact, last year, end of last year, the European Commission published a supplement after the fourth edition. This is a supplement to the fourth edition. And in this supplement, you can download it from the internet at the EU bookstore. These determinants for a successful implementation are also described. They describe 7 steps from how to go from an initial pilot program to a full implementation of a screening program. I go to physical technical quality. Why is physical technical quality important? And we have to realize that we buy information by dose, with the dose. What I show you here is if I have a normal mammogram, this is in a phantom image, and you see there these nodes of these small lumps here. This is with normal dose. If I reduce the dose by half, you see I increase the noise and my contrast is, my information get less. And if I have only 1/4 of the dose, you hardly see any difference. If I look at this at microcalcifications, these are the normal dose. There are here, in each block there are 2 microcalcifications. But if you see, if you use half the dose, those microcalcifications are less visible, and in 1/4 of the dose you're hardly visible. So image quality is dependent on the dose and the detector. So what I already said, you buy information with those. We have been in a time that from analog mammography to CR mammography to digital mammography, we have been able to reduce dose with a good signal-noise ratio. But you have to know also what dose is acceptable. And if you look at the dose, if you increase the dose, you have a better contrast. And if you enhancement, you can also have a better. This is by contrast enhancement. You have also some gain. This is my last slide about technical quality. We had, oh, sorry, I have to go back. These were the CR systems. The analog systems were still a little bit, could even be higher. The CR systems, I have deleted the manufacturers, but you see, CR, what is the remedial dose level is quite high still. And nowadays, with the digital systems, we have seen that we have even further lowered the dose to have a good image. Then I come to a next point, and that has been already been mentioned a few times, that we need a good software system to do the screening program. In 2006, when I was the medical director in Fribourg, I was also charged to develop the software screening system. And first we started with a normal sort of computer-based system, but in 2009 we wanted to go to a web-based system with also transport of images. And now we have a complete web-based software system for screening. And I will tell you a little bit about our system so that if you have any ideas, because it might give you ideas how to do it. We have a comprehensive web-based management system that is installed on a secure data center. It allows the management of demographical and medical files for one and many cancers. It's not only for breast cancer, you can also use it for colon cancer, cervical cancer, prostate cancer if you want. There's a workflow manager that's also a web-based orchestra of the digital breast screening program. It manages the digital documents used in the breast screening program, the images, the questionnaires, everything, and pilots the transport system. At the end, we have also a transport system, and that secures the digital transport from mammograms, DICOM documents over the internet, and etc. I'll show you some information about it. But first, I think everybody of you knows the analog system. You have an analog system, you make the film, you develop the film, you put that in the developer, you have an image, and you read it on the screen. Then afterwards we had the CR system where you have you change the film for the cassettes are read, you can have them in a PAC system and you read them on a screen, or still you print them and you read them on a viewer. Now with full field digital mammography, it has been changed completely. We have immediately processing and the images are visible on a screen. You can store them on a PAX, you can store them on a CD, you can store them, you can still print them and have a normal image. But full field digital mammography brought a number of issues, a number of advantages, and that is because nowadays the changes are between the information is digital, it's not analog. The medical information is on the film, now the medical information is here. The archive is here, a big archive there, it's a PAX, you have a transport, you have to bring the things, now you can send it over the internet. The information on the patient is is printed on the film, and here the information is on the DICOM, the metadata. But there are also very much differences. If you talk about digital mammography, it's not one system. There are different manufacturers, and the problem is that they don't talk to each other. They have different production of the images, the acquisition, the archiving of the images. Everybody has their own packs. Presentation of images on the workstation. Do you have it on for presentation? Do you have raw images? It's all kind of different. There is not enough standardization for it. You have post-processing material, you have 3D images, you have PAX images, and you have different reporting systems. So what I want to talk about now is how can you organize your workflow of digital images in to me, an optimal way. When in our system we invite women and we send them an invitation, and on that invitation there is a number, and if they can call us for an appointment. Also they can go to the internet and log into to a website, and with this number and with their birth date, because their birth date they know themselves, they can log in and they can make an appointment. If the appointment is made, it is registered, and if they make an appointment in a radiology unit, that number gives this lady information from immediately who it is, and that information is being transported over the internet to the communication center and checked in the screening center if this woman is eligible. Is she allowed to do the screening? Is it really a patient, a person that is invited? Yes, this woman is invited, it's okay. At that time, if we have old images in the archive, the central archive, one archive for the whole of Switzerland, the images are sent to the radiology center where she has made her appointment. So the previous images are available in a letterbox, in a digital imaging letterbox. She comes for the mammogram is made, and also sent to the K-box. And then in that time, the K-box communicates with the communication center and checks, okay, is this mammogram from this woman the same, and is it right that the mammogram which is coming in the K-box, do they have to be linked together? So we change some information in the accession number so that this image are linked together, and then they are pushed again to the archive, and afterwards immediately to the workstation for reading, and for the second workstation for the second reading. So the first and the second reading receive at the same time the image. We don't say it's the first reading or the second reading. We have two readings, because sometimes the second reading is done before the first reading, but that doesn't matter because it needs two readings. They do the reporting, and the reporting is also automatically communicated to the communication center, and that comes then back into the screening center. This is all automated. You don't even see it. It is there, and it works fantastic, in fact. So what do we do if you have an appointment manager? What should an appointment manager do? That is a web-based application. That's very universal. You can just, on each system, you can have access. It is only accessible now. For me, if I work on it, it is only accessible on certified computers, because, of course, if I have to get medical information, I cannot have information. I cannot use any computer to do it. I have to have a security certificate on it. There's a direct name feedback if you fill in the number. If on in an information, in an radiology center where they have also certified computers. If they fill in the number, they receive immediately all the information what we have from the lady, her name, her last name, her maiden name, her address, and her date of birth. We don't know what is her nationality. We don't know what her, in which economical, socio-economical groups they belong. But with this information, we have, of course, enough information to make an appointment. This information is uploaded into the RIS system. You can also, if you make the appointments and you have your own RIS system that gears the mammography machine, it can be uploaded. There's an interaction. It's all HL7 compatible. And there's a validation of all the appointments. So we try to gather all the appointments in a row so that there's not enough free time between the appointments. This is how our web-based application looks like, and this is how the appointment manager makes. You can say this is on one day, they have only a screening day on Wednesday, and then here is another calendar where they are, where you can choose your dates. How my screening set up is here. You see here a workstation in a dedicated table, and then you have a reporting system on the right side. We use for the radiologist a very modern reporting system. Because if you read a lot of mammograms, and normally our lists are about 60 mammograms in a list, that cost about an hour to read. And then you don't have, an hour reading is very intense, but you don't have to do too much mouse movements to do it. For a negative case, you only need 3 mouse clicks to have it finished. And then we have all the necessary information. We have, in the past we used paper form, but now we have the same information here. If a woman has a lesion anywhere in the oblique or the CC view, you can click on a lesion here. This is microcalcifications, a lump, and radial. There's an architectural distortion. This is an asymmetry of density. You can just take this image and you tear it. You put it into this place, and you can use also the radiographer who has made the mammogram can put information in this drawing to say if there are any nerves or any nevus visible. Automatically, when you pull in that information, the information has been registered here, and you can say you have to say if it is in BIRATS 1, 2, 3, 4, or 5. And then you can also say what is your recommendations to continue and give any further comments. Of course, if you are one reader, you only see one screen. This is a screen where what we use for the consensus conference with all our cases. All our readings are automatically compared, and if there is one positive or 2 radiologists say a positive result, all these cases are being discussed in a consensus conference. And since a year I work with consensus conference, and I believe that is absolutely the best way to continue. I work with about 18 radiologists, and they are distributed over 10 centers. And each of these 10 centers I have with 3 consensus conferences every week, where 4 of the centers or 3 of the centers are participating. There are always 4 radiologists in a consensus conference. All the radiologists receive all the positive cases. So they are not coming to my office. They remain in their own center for their own workstation, and all the images are being pushed to their workstation, and they have the same list. And then we start a consensus conference with a Skype conference. We call them, and we start discussing case for case. And then we know they can say what they see, why they have said it positive, why they said it negative. And my experience with this is that after a year, most of the radiologists have now the same terminology. They classify the lesions the same. The recall rate goes very much down. My recall rate is currently at 3% in the first year. Now I haven't seen that anywhere else, but people are really discussing the cases, and then they can say, okay, can we wait 2 years for that women come back, or do we have to recall it now? So it makes also the radiologists much more aware, and they are very happy that they can share the information with each other and that there is not one that takes the final decision. Then we automatically, after when it's positive, the women, we send letters to the doctor, and that is automatically generated in a PDF file with all the information of the consensus conference. The doctor receives a CD from us, plus where the lesions are being located, what is the information. We thought this was a suspect lesion. There's a structural alteration in the lesion. It is progradient, it continues. So all that information is there. When she had the mammogram, what is the breast type, and with this information they can do the follow-up. Also in the screening system, the software we have developed automatically generates monitoring reports. So you can see this is a monitoring report from more cantons together, but the information is in fact the same. We know what is how many participants, what is our target population, have we invited everybody, what's the participation rate, what is the participation rate in the first round, what is the participation rate in the incident round. Then also you have information about how many mammograms are positive, how many cancers have been detected. All that information is automatically generated. So you push on a button and you say, I want to have this time period to be covered, then you get these results. We normally make results of a whole year, and we compare it between the different cantons. Also, we have information about early detection. What is our DCIS rate? How many lymph nodes are involved? What are the cancers with smaller than 1 centimeter, with smaller than 50 millimeters, which are cancer stage 2? Now, all that information comes out automatically in aggregated data. So, where are we currently with the digital mammography? Because you have all digital mammography machines, but you can also use digital mammography for distant reading. Even that I have many radiologists in Switzerland, I send mammograms also to Germany. Some programs have not enough radiologists, and we send all their mammograms to Germany. About 6,000, they go to an external radiologist, and he is very qualified, and he feeds back the information and also participates in a consensus conference. You can do the teleconferences, what I said. You can ask for expert opinions. You can do sensitivity and specificity testing, because it's easy to make a test set where you can do further training. You can have automatic density measurements. You can do also quality control for radiographers. That's called, we have developed a PGMI system, but it's also automated. We randomly select 40 cases from a radiologist over a year, and we grade them and then give that feedback to the radiologist. And of course, with digital mammography, you have the option of tomosynthesis in screening. I think I don't go into that issue from tomosynthesis at this time, but that will be probably a case for the future. So coming back, I have discussed a number of the physical-technical parts, the invitation, result management, follow-up and monitoring, but also a very important issue is standard operation procedures. If you want to have a good screening program, you have to write down what you do, because if you are not there, the other ones have to do the same thing. What are standard operation procedures? That is a comprehensive information for commissioners, providers, other stakeholders to inform on the implementation and the delivery of the screening within the screening program. So all processes, how you do to make an appointment, how you do the reading, how do you do the sending the positive letters, everything has to be written down. And I think you have here, I heard this morning from 5 different regions a program. If you write down, if you make similar standard operation procedures, you can exchange them. At least you come one step further, closer to more harmonization. This is a slide I also added today, because I've been hammering on political commitment of a screening program. But how can you convince politicians? They want to have information about costs. How much does it cost and how effective it is? And in the Netherlands in 1990, they started with the screening program only based, of course, on the information of the randomized trials, but also because they made a cost-effectiveness analysis, and they have developed a program that is a MISCAN program, that is a computer simulation model. You can put your information in it, and you receive your information back of if it is cost effective. They have used it for several countries. They have used it in Spain, in Germany, in Australia, in France, the Netherlands, in UK, also in Switzerland. They can say, if you do breast cancer screening and how many deaths are prevented if after 25 years of screening, then you can see, and you can calculate how many life years are gained. You have to discount something, because if you do a screening now, your effect will be 27 years later. So you have to discount a number of your effects and also in your price. And then you can say, what is the cost-effect ratio for lives? How many euros cost a life year gained? And that is, all these prices are in a very acceptable range if you calculate them well. Also today I've been asked from, okay, are there any other reports on screening than what is in the literature? And I didn't put down the internet site, but it is in the Netherlands, the Health Council have been published this year, an excellent report on 25-year screening in the Netherlands. And that report has been, since 2 weeks, it is available complete in English. And it has a lot of information how to run a good screening program. You can find it on the internet on the www.gr van gezondheidsraad.nl, and you find immediately publications in English, and you find this as the bottom of the top listed document. What is in fact the MISCAN model do? It says if I do a screening, there's no cancer. There's nothing. But if you have a preclinical DCAS, what does it do if I have a clinical diagnosed DCAS, and what is the cost? And if I do it in mass screening, what is the cost? And then at the end, they compare how many breast deaths are there from breast cancer and death from other causes, and you compare the two with each other. So you have all these stages. You see what are the clinical diagnosed ones and what are the screen detected ones, and then you make the comparison with each other. And then you come to, you can also use different strategies. If I say I want to screen every year, I want to screen every 2 years, I want to screen these age groups, you can add all this information in it, and you get a cost to that intervention. In the Netherlands, when they started in 1990 here, it was predicted that the cancer mortality rate would about be constant. I think that's a little bit optimistic. It should have gone down a little bit. But they have predicted with this line what it would be, the development of the mortality over a number of years. And then this information was already been known in 1990. And when they made the program, they said, this is what it will be if we don't do anything. And this is what it will be if we do the screening program. And the model predicted, in fact, this is what we have observed since then, and since from this point to there, they have now about 31% mortality reduction. Okay, we may question now that this mortality may have gone down also by the better clinical treatment, but still, the mortality reduction is very significant there. Let me see, I think I came to my end. I also want to thank the organizers very much for the invitation. I've enjoyed it very much to be here, and it was a pleasure to meet you all. Thank you. Thank you.
Now, the last lecture will be by Dr. Omar Bayamin, our senior general surgeon. He is the medical director of Prince Saud bin Jalawi, head of Tumor Early Detection Administration at Al-Hassa Governorate, and the title is Screening in Al-Hassa.
Want this one? Oh, you want this one? This one I just turned off.
No, it's okay, this one.
Okay.
نعم. البانل discussion.
Bismillah ar-Rahman ar-Rahim. I think we reached to the last lecture in this conference. And I got this chance to thank our speakers and moderators for giving such informative lectures that I hope and wish it will add to our knowledge to improve the breast screening program in our countries. I think Al-Hasa is not different from other regions in Saudi Arabia or perhaps the Gulf areas. I think we share the same problems, the same challenge, the same difficulties. So I'm gonna make my lecture a little bit shorter because this is the same thing. So. We are all in the same boat. We share same problems. But some countries, they are a little bit, have more experience and have better programs. And the others need to improve more. Saudi Arabia is a part of this boat. Saudi Arabia is extended from the Gulf, Arabian Gulf to the Red Sea. It is a big country in the Gulf area, approximately 2 million plus kilometers square. It is divided into 13 regions. Cancer. Cancer is a major public health problem all over the world. 1 in 4 deaths is due to cancer. And it is clear from Saudi Cancer Registry report that the incidence of cancer is on rise in spite of the under-reporting of clinically diagnosed cases in our population. We will continue to work hard to publish cancer-related mortality in Saudi Arabia in the near future. Breast cancer continues to remain the most lethal malignancy in women across the world. As has been discussed before, and the most common cancer in Saudi Arabia is the breast cancer. In 2008, there was 1,153 cases of breast cancer. In 2009, it is 1,308. So it is increasing almost yearly by 13%. The Eastern province is the most common, the higher incidence are in the Eastern province. Then it follows by the Riyadh and Mecca regions. In the last reporting, it shows that Mecca is the second most common region for the breast cancer. It's followed by Qasim, Jawf, Medina, Tabuk, Jazan, Hail, Baha, Northern, Asir, and finally Najran. This is the 13 different regions in Saudi Arabia. Starting of a screening program or early detection program in Al-Hasa. As there is a great number of breast cancer cases in our Eastern province, which consider the first red area in this concern, according to the levels or to the regions of Saudi Arabia. So a great effort must be directed in Al-Hasa aiming to breast screening program, early detection of cancer breast as a primary step for the other prevalent cancer. Prevention of breast cancer. Challenges at the start of the breast cancer screening. There was no awareness about cancer. Culture refusal. No trained medical staff. No breast screening clinic in Al-Hasa Governorate. No advanced diagnostic facilities. No breast image radiologists. Few female X-ray technicians. No mobile mammography trucks. And no support in terms of financial. All these things leads to breast cancer late diagnosis. I have made 5 years ago a study to know the level of awareness, and I found that it is almost 4% of population they are aware about the breast cancer. Culture refusal. The culture don't accept even to hear about breast cancer. I have done a lot of awareness program at the beginning, 5 years ago. You found ladies, they don't want even to hear about the cancer. They even don't accept any pamphlets about the breast cancer awareness. So we reached to such a case that came in a very late stage, even with metastasis. Effort to overcome these problems, increase level of awareness of the community for the values of breast screening by public health education campaigns. We have reached to the village of Al-Hassa. We have done a lot of awareness program there. We make a program for the secondary schools. It is almost annually we do an awareness in the secondary schools. First of all, the incidence of cancer in our area is lesser than, at the age, is lesser than Western countries, this is one. The second, they are the mothers of the future. So the third, they are sending their message to their mothers and relatives about the importance of breast screening. Also make some programs in the universities. We use summer activities because most of the ladies are in vacations, and they usually go in the evening for the summer. So we use this summer also for doing some programs and activity for awareness of breast cancer screening. Using the malls. No trained medical staff. This is one of the problems that we face. Who's going really to educate the community? We have less number of health educators. So we have make a annual program for the improvement of the skills of the health educators. We approach the BHC. Almost all the BHC, we approach them. International symposium to prepare and develop the health educators. Medical education through the videos. Where is that? You know, in our cultures, it's sometimes hard really to reach to the houses, to reach to the women that really targeted for the breast screening. So we are trying to find different ways so we can get those women for breast screening. One of them, during the campaigns, we are getting their names, their telephone mobiles, and we can call them to come for the breast screening, especially those who are interested. One of their difficulties, if they want to reach the breast screening clinic, they have to go to the BHC and to see the doctors, and the doctors, sometimes he will refer, sometimes he will not refer if he's not aware about the breast screening program. And they feel difficulties to go to the hospital. So we find another way for them to use the electronic device like emails, or we make for them a website so they can, at home, register their names, and they will get the appointment immediately through SMS messages. This is just an example, small video, an example for a lady or a girl that she heard a bad news that one of her relatives or friends died. So she's trying to search for SMS messages that she received before. And then she go to the website, she enter their names, immediately get the appointment, and she follow the center. I will let you see in a short.
الو، صباح الخير. ايش؟
She will fill this form and it will be sent. Immediately she will get a message that her appointment or her request has been received. Even she can select the hospital that's near to her or the center that's near to her. Her request, it will reach to the nearest hospital for her, and she will be given the appointment for breast screening clinic.
سارة محمد.
نعم.
تفضلي معي. بالمرحلة المتأخرة.
حياتنا تستحق.
We are trying to make the shortest and easy way for our ladies to come to the breast screening clinic. One of the challenges that there was no breast screening clinic in Al-Hassa Governorate. And we decided in 2009 to establish the first breast screening or early detection clinic. Now there's 3 clinics in King Fahd Hospital, Hufuf, and 2 clinics in Prince Saud bin Jalwi Hospital, and 1 clinic in Maternity and Children Hospital, and 1 in Al-Ayoun Hospital, and soon will be in Al-Jafar Hospital, and we have 5 main hospitals or general hospitals. The number of women screens at the breast screening clinic in 2009, the number was 219. So there was less number because people, the level of awareness at that time is still very low. By the time the level is increasing, so in 2010 about 1,480, and 2011 2,206, in 2012 3,844, and last year 4,123. In total, about 11,000. Means of referral for women, as I have said, is through the BHC, public awareness campaigns, or through the email, and finally through the phones and the internet. No advanced diagnostic facilities. I think still we lack a lot of mammographic, digital mammogram machines. MRI, we have only now 1 MRI, and there is news of recent procedure like genetic counseling. Now, number of digital mammogram is increasing up to 8, 5 in governmental hospital and 3 in private hospital, which they are doing the mammogram free but with arrangement with the Minister of Health. Mammographic trucks, we are waiting for the, maybe within 6 months we'll have 1 new mammographic truck, or the first mammographic truck. MRI diagnostic facilities, we have 1. Genetic counseling, we have started for genetic counseling recently, and we have sent 13 cases. The first case was reported to have BRCA2, and awaiting for the other result. In the future, I think still we need to increase the level of awareness to our community. In this year, 2014, I have made a study to know the level of awareness. As I have said 5 years ago, the public, about 4% of the public, they are aware of breast cancer. In this year, the study shows about 51% of the public, they are aware in a way or another about breast screening program and breast cancer. Mandatory screening mammography. I don't know if this is applicable or not, but as we have programs for the premarital test, and it is a must, I don't know if we can apply this in our country, that a lady, she cannot do anything unless she will do the mammogram. Increase the number of breast screening clinic, and to have Al-Hassa Breast Cancer Center. This is one of the, I don't want to say dream, but inshallah it will be a real soon. Thank you so much.
Thank you, Dr. Omar. Now, I think the closing ceremony will be with you.
So if we can invite the speakers to the podium, please. Okay, yes, دكتورة تفضلي. Can we have a microphone to the first row there?
Bismillah. I would like to thank organizer for this very successful program, and this conference is very informative, and it's actually useful to sit together in our regions and get international experience from a well-organized program. My questions to Dr. Omar. Have you thought about developing breast physicians? In our screening clinics, in our small experience, because we have our breast surgeons, they are very loaded with symptomatic patients. So in order to have assessment clinic, I saw there is curriculum from Australia and UK. They have the post for breast physicians. So what I did, we trained the family practice medicine or the physician who's interested from different backgrounds, clinical backgrounds, gynecologists or anybody who's interested to pursue this, to be in our screening. So I developed kind of curriculum using Australian or UK, and we put them in the assessment clinic. So they will assess patients in our screening, and then they will, if there is recall from radiology, they will come to the breast physician. They will do initial assessment screening once, and then they prepare the cases to be discussed in our breast MDT. And if if patient diagnosed to have breast cancer, then we'll refer them to breast surgeon. Have you thought about those development kind of things?
I think no. Actually, it's not. Actually, we don't have such, unfortunately, such things. But we can really think about it and study this suggestion, and hope we can really train many people, especially on BSCs and in the breast clinic, assessment clinic, and hopefully we can really jump to such thing.
I think even I went to our medical educations. If we try to do it as a residency program, it's like if there is any of your regions that are interested in developing breast physician, then we can put it as a curriculum in the Arab board, and you get certified. So we'll able to.
It's very good suggestion.
Have you ever, from Dr. Christopher, did you go to the breast physician post, or did you train people to do assessment, not by specialized surgeon, but just by breast physician, and any of other screening assessment clinic?
A specific breast physician, no. When we ask women to go for a further assessment, we send them or to to a radiology center where they do further assessment, or they go to a breast center where they have people there. But specific breast physicians to do the examination, we don't have. Breast centers, they have a specific breast cancer nurse, but that's only for when cancer is detected. But for the assessment part, no.
It is, it's kind of internists, but they are interested in doing kind of procedure also.
Yeah.
So trained in radiology, trained in how to do procedures. And at the same time, the assessment, but they will not do operation. So the operation and full assessment indication for surgery will be by breast surgeon. So
Yeah,
it's kind of, if we are planning to do kind of widespread organized screening clinic, national screening, maybe we thought to develop kind of curriculum so encourage people to do it.
It depends also on in some countries, women are referred after a positive mammogram to their GP. In other countries, like in France and in Switzerland, they are sent to their gynecologist. So there's some people are sent to an internal medicine. So there is not a specific specialization what says there is a breast. This is a breast physician.
I think, it's idea to think about it since there is a lot of demand in our specialty. So if we could train that, the community medicine or family medicine to do that stuff will relieve them from seeing by specialized surgeons or internists.
One other possibility at MD Anderson we have, now I realize it's a very high volume center, but we have a cancer and prevention which is basically a screening clinic, and then also an undiagnosed breast clinic. And certainly there are some physicians that oversee it, but we use mainly nurse practitioners and physician assistants, so sort of physician extenders. I don't know if you have a comparable system in Saudi Arabia, but we rely on them greatly. And because it is such a narrow scope of practice, they can be adequately trained, they can work independently, they have a physician that they can go to if there are issues, and they have standardized protocols for knowing when a lesion needs to be presented at our multidisciplinary benign conference. They know when to refer it to a surgeon versus medical oncologist and things like that. But we use physician extenders all over the place, and we find that they're great. It really helps.
In fact, there is a country that has it. It's Germany. In Germany, when the women go for screening and they are positive, they are, by the screening center, referred to an assessment center. And the assessment center is linked to the screening center, and there are specialized people. Also, the same radiologists who do the screening, they also do the assessment.
Excuse me, I would like to talk. In Jordan, we had, you are talking someone like who will do the clinical breast exam. These can be registered nurses or midwives. And this, I think the UK, they have a training to be a clinical breast exam nurse or registered. And we tried this in Jordan. We developed the clinical breast examination manual, and they tried to force that they will teach it for the nurses and midwives in the college and university. And we had issues with this because officially the Ministry of Health, up till now, since we started, they cannot legalize for the nurses to examine the patient. Yeah, this is the idea. I mean, the labeling, I don't know what is the other issue also, that we have male and female nurses. So this will be also like, why to teach this one, not to teach this one. So till now, we could not make it official. We trained the midwives and nurses in the primary health care center to do the clinical breast exam, but they are not officially labeled as examiners or have official label.
Can I put a question to Dr. Christopher and Dr. Omar? Over here, the chairperson. Right to your left. Yeah. There are some who, just to be a bit controversial, who would actually question whether a screening program should be set up, or let's say they expect that there will be many challenges with setting up a screening program in Saudi Arabia because, number one, the incidence is far lower. The affected group of patients is much younger, and therefore you'll have a much higher rate of maybe missed cancers or false negatives or recalls, and the uptake won't be the expected, at least minimum of 70%. So what would be your opinion on that?
Yeah, I showed in my presentation that I'm a little bit puzzled. Also puzzled in the fact that you say you detect your cancers in a very young population, but the number that you detect is relatively low. It is also, if I looked at the population pyramid, you don't have many elderly people. You don't have women in the 50s, 60s. So, but if you see in the next 20 years how that will develop, then there will be many more women coming in that age group and also having a higher risk of breast cancer. Because breast cancer is related with age. With aging population, you will have more breast cancers. That you already have so many breast cancers in young ages is really surprising. And I have no explanation for this. But it's also the question if you really have more than other countries, because if you look at the standardized rates, they are almost the same. What are the questions? What to do with this information? Like on the other hand, I can see that you say we start screening at a younger age. The problem of overdiagnosis is not so big in the younger age. That's more in the elderly age, because there is so much time span there still that if you detect an early cancer, that cancer can develop into an invasive cancer. But it is also possible that you do overdiagnosis. That's because you might also detect cancer that may never have had anything to do. But we don't know it. What I heard about the different screening programs with their recall rates, I think there is still certainly something to be done, because that frightens people too. If you have between 8 and 20% of recalls, that is very high. The recommendations are more or less from 7% in the incidence, in the prevalent round, a maximum 5% in the incident round. Because if you screen 1,000 women, you will find about 8 cancers, even less sometimes. So you should not call back 200 women to find back these 5 cancers or the 8 cancers. That's not ethical too. So you have to be more specific there. But that means also that you need better training. So there is still, it is a very complex system to do a screening, and you have to find a balance in that. You cannot have it in at one point very high, and the other point it is insufficient. You have to find the balance that it is the whole service has an equal of a high level of quality assurance.
Yeah, I also think, I believe it was Dr. Mushbab, is that his name, that presented earlier today? And I don't see him in the audience right now. But he said that obviously the incidence is low right now, but increasing. And he made a very good point that now is the time to start working out all the logistics. Now maybe you can cover the area with, 8, 20 units in a region, whereas in 20 years you're going to need a lot more, and it's going to be a lot harder to get this started. So I think that I commend you for realizing that this is an issue, and it's going to become a bigger issue as time goes on, and starting to do this painful process of getting screening in place, because as all these presentations we've seen today, it is not an easy process to get this started in any way, shape, or form. And it's a lot easier to get it started now on a smaller scale and ramp up than when there's an urgent need for it.
Okay, thank you. Yes, front row.
You got.
I have a comment. I mean, at the end, can't we have a uniform manual, protocol, guidelines, and to be part of continuous education activities? So it should be, because to detect 1 out of 1,000 is difficult. But when this is, distributed all over, the BHC, nurses, doctors, everywhere, at home, it should be easy. Because all this will, at least diagnose or at least send the suspected cases to the referral center or referral unit. So I think what I advise, a uniform protocol or guidelines for screening, and to be part of continuous education, like other activities of hypertension, diabetes, asthma, and other. Because once this is overwide and known with everybody, with BHC, with every doctor, with every nurses, with all nurses, and also should be known for home or for everybody, and it should be easy for detection the cases, and it will simplify the case.
So your microphone was going in and out, so I caught part of that. Could you hear? I'm sorry, being this far away, I couldn't.
If I want to summarize it, he's asking for a guidelines.
I think, if I'm not mistaken,
they have a guidelines for
For who should be screened?
Yeah. Do you have a breast screening
Guidelines? Well, I think that depends on who you ask. Every think tank seems to have a different guideline. In America, we go by the American College of Surgeons the American Cancer Society recommendations, and that's a baseline at age 40, and then once a year after that. Where to stop it, we usually say at the point where if a woman you think still has 10 years of healthy life expectancy ahead of them, then you should do a mammogram. I don't know how you predict that, but that's sort of how they left this vague. Do we stop at 75, 80, 85? As the population gets older, it becomes a little bit more difficult. But certainly, there have been groups in the U.S. that have recommended starting at 50, doing it at every 2 years. The U.K. is recommended every 2 to 3 years. I don't know.
There are guidelines and there are guidelines. I was once at a conference in the United States about guidelines, but in the United States, guidelines are more recommendations from interest groups.
Right.
And
it's more what insurance will pay for. They put these guidelines so the insurance says, okay, we will abide by these, but no more.
And if I compare that to the European guidelines for quality assurance and mammography screening, that is a political recommendation. Even the politicians, they say if they want screening, it should be done according to these guidelines. They don't take the guidelines. We don't recommend screen which women, but we only recommend how to do it. What are the levels of quality to achieve if you do the service? That's another type of a guideline than a recommendation.
I think we have one suggestion. Now this is the first international conference for that, for screening. So on the next, or the second one, the interval between the two, we need communication between us, that we can share all our ideas, take your ideas and give you our ideas to reach the next one, showing that we all share the principal steps to be the same. And if we do that, I think we succeed.
Well, and I would say even just amongst the Gulf country physicians and even the Saudi physicians here, we heard each region today. Now you all know each other. You have an email list. You can email and say,
that's
hey,
the thing. That is the thing.
Let's say these are going to be our guidelines. Let's pool our data and let's see where we're common and can move forward.
Pool your strength.
Yes,
Then
exactly.
pool your data.
Because you've got great systems in place already.
Okay, Dr. Ahmed.
Thank you very much. I would like to thank the speakers for their very informative presentations. My simple question to Dr. Suzanne. From some surgeons, they prefer for a single localized breast mass to do excisional biopsy. And if we refer for biopsy, trocar needle biopsy, they prefer no excisional biopsy. Is there any background or preference about that, or is there any contraindication, not contraindication, spillage of cells? Why the surgeon prefer excisional biopsy?
Why do they recommend it? I'll give you a couple of reasons, and some of them are pretty cynical. I agree. In the U.S., it's about money. It's a procedure, and the quickest way to get the money is to say you have a breast mass, I can take you to the operating room tomorrow and take it out, and then we'll figure this out and figure out what to do, knowing that only 20 to 30% are going to be cancer, so only 20 to 30% are going to need a second operation. So that's the cynical side of me. I think that there are some places that maybe don't have radiology or the appropriate resources, so certainly in those instances it's appropriate to do an excisional biopsy. Sometimes it's education, right? Some surgeons were trained before we had standard stereotactic biopsy and things like that, so that's the way they always did it, and why not continue doing it that way? Given the option of a percutaneous biopsy versus an excisional biopsy, I cannot imagine a circumstance that an excisional biopsy would be preferred over a needle biopsy. But I see it. I mean, I had one last week that the lady drove by our massive MD Anderson. You saw a picture yesterday. It takes like blocks and blocks of the city. Drove by it on her way to the Surgery Center where a surgeon did an excisional biopsy, and what do you know? Positive margins, it was a cancer. She had to have a second operation. You know, now she's got a bigger defect. And it was just like, why did you do that? So, but I don't, you know, that's the cynical side of me. And so some people may have a reason that they want to excise it versus percutaneous, but, you know, certainly that's becoming more and more of a quality metric, the percentage of percutaneous. Now, sometimes there's circumstances. Sometimes the radiologist will come to me and say, it's too close to the nipple, it's too close to the skin, we can't get an adequate sample, or it's discordant pathology, we've tried. And in those circumstances, obviously an excisional biopsy is warranted.
Last question from Dr. Muhammad.
Thank you, Dr. Omar, about this very nice and very interesting conference. Inshallah, you will be second, inshallah, coming year. My question for Dr. Christopher and Dr. Suzanne, you are speak about the present. What about the future? This is a conference about the present and the future. I need what is your opinion? What is the future, inshallah, about this breast screening?
I think that as we get better about risk factors, whether it's epidemiologic or host factors, genetics, breast parenchyma, whatever you want to have it, I would like to think that in the future we'll have a better way of screening people than telling millions and millions of women you have to get a screening mammogram every year for 30, 40, 50 years of your life. That there may be a way, just like colonoscopy, that you get one, and based on that, then we decide what your screening interval is going to be. But that's the non-radiologist standpoint.
Yeah.
He may know like new imaging and things.
No. I do agree a lot about that. I believe that in a lot of screening practice will be adapted to more personalized screening. That will be the case, but that is not your future here. I think you have more basic problems here than the luxury problems we have to deal with overdiagnosis and all the controversies, and with the mass screening as one size fits all. That's not the case. We can't do that. But that's, it needs also, again, people need to be convinced. You need to have, it needs more money, it needs resources, because you will give other services to other women. And each new decision brings new other challenges, because why do you do this one and why not the other one? And there will be always cases that fall in between. So it is not so easy, and it's, my experience is if you make a new recommendation, it takes quite a while before it is being implemented. And then before it is being implemented everywhere, that's another thing.
I think now Dr. Omar have the last few sentences for this meeting. Huh?
I think we have done a great job with imaging so far. Now we can find the small cancers like 4 millimeters. Really, this is a big advantage at development over the past few years. We can find the small cancers with MRI now, like less than 1 centimeter. With DCIS we are finding. So now I think imaging has done really a great job so far. We are thinking really in the future, what I personally believe now, for the young patients, less than 40, which we are not able to do now for the mammogram, I think there have to be some kind of research to find these small cancers early, like something like a blood test maybe. Because I believe these tumor cells, they secrete something early in the early development. And with imaging, we're finding them early. So now we have to find something earlier. And this we need other research or something. Still, it's not in there very soon. Thank you.
I think we reached to the end of this conference, but I would really appreciate if we could have some recommendation according to what we hear and what we know, where we stand here in this program in Saudi Arabia. So really, I would love to hear if there is any recommendation that could support to improve the breast screening program in our country.
recommendations from, yeah, I mean, I think as we've talked today, centralizing it, you know, joining your forces together. You all have got a lot of the same ideas in the different regions, and are doing things in much the similar way, and I think joining forces and joining your data, it becomes a very powerful tool. You know, there are a lot of physicians in America who have become very academically and very, I don't know, nationally famous because they started using the national cancer databases instead of looking at their one institution or their one state. Now they look at the millions of people in the National Cancer Database or SEER database, and it powers a lot of things. But I think especially when you're setting up a screening program, you've got plenty of data. Pull it all together.
First, you have to have the data before you can go to the politicians. Because one of my recommendation is you have to join your forces together and go to your politicians to say, we need this, we need a screening program. You have to support that with data, but you have to do it all together. And I think one of the main lacks, and I've seen that in other countries just close to you, that is possible, to have to issue an invitation system. With an invitation system, they achieve 50% participation rates. Here, your participation rates are almost neglectable. For 8,000 people to do a screening program in a region which counts over 1 million women, that's 200,000 women, that's not logical. That there is a lot of waste of resources, because the more women you serve, the cheaper your service will be. Because now, if you see what are your costs for the women that you have been serving, that's very high. But if you do 10 times as much, or even 50 times as much, you will have a much better cost-effective ratio. But really, I believe you have to start with, and there must be a way to identify women to come to the screening program. You don't have addresses, I've heard. You don't have social security numbers, but there must be something where you'll be able to identify women. I remember that in Greece they sent the invitations with the water bill, because otherwise they would throw it away. But they cannot throw the water bill away because then they don't survive. So at least they read the information. But they have been very creative to find solutions. There must be also solutions for your country.
Yeah, I think one other thing, and Dr. Mushbab, I'm sorry if I'm saying that totally wrong, touched on it, and I think it's very insightful, is that as you have more breast cancer patients, you have more breast cancer survivors. And those can be a very vocal force. And certainly in America, they are the ones that lobbied for all of the breast cancer legislation. I mean, breast cancer is very protected in the US. The insurance have to pay for reconstruction. They have to really pay for anything. And it's because the survivors were, that advocacy group was so incredibly strong. And so I actually think getting the data is important, but if you want to pull on the emotional heartstrings of politicians and the country at large, you need to give the survivors a way to engage and give them a voice and give them power, make them proud of what they went through and proud of telling people, so that, you know, other women see it survivable and they see the reason for screening. So.
Yeah, I really support that point, because in Europe you have the organization Europa Donna that is covering over 35 countries. I don't know if any Arab countries are there, but they have been wonderful work also in lobbying at the politician level and to create awareness also with politicians, because they cannot deny, if you are in a democracy, they cannot deny the voice of the people.
Dr. Amma, I would like to from our experience in Jordan, to mention that awareness and education was very important, but this has to go parallel to at the same time with the building the infrastructure, like preparing the mammography units, to prepare adequate units and sites where the women can go, and at the same time preparing the manpower, technologists and radiologists. And also there has to be pathologists and surgeons who are specialized, because the focus was in Jordan at the beginning mainly about radiologists. But still you have at the same, it has to go parallel together, expert pathologist and expert breast surgeon to deal with the situation. And the other thing at the end, teamwork, because as you mentioned, like there are multiple efforts here in Saudi Arabia, and really everybody has his own experience. Some are following the American College of Radiology, some are other protocols. So maybe if you put together, you can have the best guidelines, and then can be nationalize and practice for everybody.
Thank you, Dr. Iman. Dr. Leila. Dr. Abdurrahman, I think he has also he wrote some recommendation. First, he suggests to repeat this conference again and again. The second is to unite our efforts from different areas in Kingdom of Saudi Arabia. The third, to put a guidelines that is fixed for all the regions in Saudi Arabia, not different guidelines from different regions. To continue the awareness in the community, and to recruit or to call for the international experience doctors to be invited in Saudi Arabia to put some strategies for breast screening program, and to recommend what's needed and what's the financial support that needed for this breast screening program. The last, it needs a country or governmental support. Okay, Dr. Yes, Dr. Salha.
One thing to add is the most important, maybe nobody mentioned it, networking. You need to have a strong IT support to enhance communications between all centers.
Mm-hmm. Yeah. Mm-hmm. Mm-hmm.
Well, basically, I agree with most of what has been said. I think I also want to bring up a point that was made by someone yesterday, and that's it's better to do something than nothing at all. So there is the ideal standard that you want to aim for, but I think perhaps a more practical thing to do at this point in time is to decide what is the minimum standard that you want to set across the board, and just aim for that minimum standard and get it going. And the program will evolve along the way as you aim for the higher standards.
What we wrote regarding this recommendation, we just try to summarize the things that in all offered lecture over the two days. We hope this recommendation to be just some implementation, and we hope the next meeting or the next conference, we hope to be at least yearly or every other 2 years to be, and we'll try to find out how we going on this one. We know this recommendation not, maybe agree or final or approved by all, but at least it's a minimal recommendation or minimal standard that we'll try inshallah in the future wise. Thank you as from my side as chairman of the scientific committee and from all the people for a great offer from everybody that join us, and sure inshallah we'll meet together in coming future inshallah.
Thank you.
Thank you, Dr. Abdurrahman. Thank you, Dr. Chris. Thank you, Dr. Suzanne. Thanks for all the speakers, moderators. Thanks for those people who attend this conference. Thanks for all the members who really join and share in organizing this conference, and they have done a good effort. Some people really behind, but they work hard for this conference. Hope that you enjoy here also in Al-Hassa, and wish you a good stay, and hopefully we can do the conference again in soon, and it will be of a value. Thank you so much.